You know, it's no mystery that we are busy, and that's and that's great. The beauty of this program actually is, number one, there's some compensation involved, which has never occurred before. So it does allow you to actually set some staff time, maybe hire new staff, whatever's required. The other thing is, as the program builds, we can address those issues too. The pharmacists, my pharmacists, and the ones across the county here that are involved in this program, or have had a number of discussions, are motivated to make this happen.
Next question is going to be for Jim. Who pays for this?
Follow up a little bit with what Eric has said there too. In the past, as a payer, a planned payer, we've always incentivized physicians and pharmacists that we pay them on quantity of work done. And this model we're setting up here in Springfield is going to be based on the quality of the work that they're doing as well as quantity. So there is going to be a shift. The providers never have had in the past a reason to do quality work because there was no payment for it. And that's where the quality comes back into the providers, the physician and the pharmacist, to make sure that not only are they taking the right medication, the most cost-effective medication, they're taking it in an appropriate manner. So the cost comes from the premium and from the cost savings that we will incur in both drugs and medical outcomes.
The next question is going to be for Dr. Fagans. Family physicians, will it take business away from family physicians,
Well, you know, the new reality of healthcare requires us to be a team, to focus on things as a team. While the concept of the project may be new, the components are not. Those things like certain clinic, like Coumadin and insulin. We talked about adverse drug reactions. Coumadin and insulin are the two most common reasons to go to the emergency room. There are established Coumadin and insulin pharmacy-run clinics all across the nation, even here. And so to the extent that those types of complications can be reduced, that's already happening. That's an extension of the primary care office. The other component of that is disease management. We're not talking about broken arms and car accidents. We're talking about the big three: diabetes, cholesterol, hypertension, other things like that. Those require ongoing management and having people take their medicine. That's an extension of the primary care office, not taken away from the primary care office. Physicians want their patients to be able to take medicines and to be able to be monitored in a more appropriate manner.
How does this program save patients and employers money? Even though Doug covered it, perhaps you could.
And I've been involved with a project like this before. What you basically see is employers save a significant amount of money through this type of project. In fact, I was part of a project that we started up in Findlay, Ohio. The hospital was a pilot project, and they actually saw greater cost reductions in their healthcare insurance than, in fact, even Asheville saw. And it's pretty unprecedented. If you're part of a company and you see increasing healthcare costs year after year after year, I would say, well, that's problematic, because that shouldn't be happening. We've embraced the idea that healthcare costs will just go up every year. That just is what's accepted. And what I would say is that healthcare costs should not be going up like they are. In fact, Asheville, North Carolina, over 10 years saw no increase in their healthcare costs for all businesses involved. And the fact that you don't have to budget for healthcare cost increases is, I think, substantial, especially in a down economy. I realize this is sometimes very difficult for people to understand when we're up here saying, well, you can reduce your healthcare costs potentially over the next 10 years, not see an increase in your healthcare costs. That sounds like, well, you're lying to us, because that's not possible. And that sounds absolutely absurd. But the reality is that there's enough data and the model works, and we're just basically suggesting to the city of Springfield, what if Springfield had lower healthcare costs for their self-insured companies in this area? Would it potentially draw in future employers, future businesses? Because Springfield has lower healthcare costs than other cities around the nation. But in general, how does it save patients money? Well, you can basically build into this model incentives so that patients have financial incentives for reduced co-pays, reduced premiums for participating in this particular program.
Okay, and this question is for Darlene. Pass that down to her. Will a to participate in order to have their
I don't think there would be a requirement. I think there would be a lot of incentives that an employer would want to set out there to highly encourage an employee to participate in a program like this.